processes that you might want to consider, evidence-based practice, but that hypothetical deductive reasoning model to facilitate diagnosis, I think, is really the backbone of what we're doing here today. Is anybody familiar with what that model would entail? That hypothetical deductive reasoning model. Sounds quite academic, doesn't it? Said I'm not going to talk academic, but it's kind of an academic thought. And I think really, even if you don't necessarily know what that means, you're doing it already in the vast majority of cases. What it really looks at is almost like a scientific model, right, where we generate hypotheses, right? So immediately, you lay eyes on a patient, you're immediately starting to generate hypotheses about potentially what the diagnosis is. Are they with the right provider with you? Do they potentially need to be with somebody else? And then you're going to gather data, right? You're going to gather data. Where's the data going to come from? It's going to come from the history, the clinical exam, perhaps your chart review, and then maybe response to intervention. And then once you have all that data, right, you're going to look back at those hypotheses and determine are they supported or refuted, right? And it's challenging for us because, all we really have is what the patient kind of tells us. What we find in the chart review or what's already been done and based upon a physical exam, right? Physicians, nurse practitioners, PAs who have different privileges in terms of labs, diagnostic imaging, medications, they can do different things in terms of treatment. Many times they can order those gold standard tests. We can't do those. And so when we talk about, trying to support or refute those hypotheses, the one thing we talk about is that you're never really 100% sure, right? You're never 100% sure. And you're looking at that preponderance of the data to try and make clinical decisions based upon what you think is best for the patient. That's what we're going to focus on these next couple of days. There's some things that you have to have with that. You have to have some understanding of how to do a basic, general health screen, how to potentially screen systems that could potentially mimic musculoskeletal disorders, like the cardiovascular system, like the urogenital system, sexual reproductive system, and then we'll talk about how to do some of that, and then we'll also talk about how to do some basic screening in terms of cranial nerves and the abdominal region, because that's data that sometimes we need to get back to the physician to help them make an appropriate decision. The business of a direct access practitioner, I think that's always interesting. That's something that, PTs are trying to do more of. I gave you guys that one pre-course read by a PT named Katie O'Bright, where she differentiates, primary care PT from direct access PT, because there really is a difference there. And we'll kind of talk about what those differences are as we go through the weekend. I do want to start, though, by just thanking, number one, all of you guys for being here and taking a weekend, especially a weekend of football, and the way you guys' schedule kind of runs. The games are going to all occur during the time here, so if some of you might not be football fans. If you're a football fan, you kind of are missing out a little bit. So some of you, every time, I think we taught at Christie's place, once we did this on this same weekend, we did a little TV there, you guys can have your screens out, watching the game. I don't know if you guys are fans of anything. I think the first game starts at like 1. I think the Bills play tomorrow at like 10, so you can have your first break and watch the Bills. I want to thank all you guys for being here. And I really want to thank Michael, Christy, and Ryan, because without them, it's so emotional for me. Without them, I was here. I really wouldn't. So the training that I received here, the care that I received, the empathy and just the caring that I felt when I was here, I really appreciate it. I just want to thank them, especially. So let's go ahead and get started. We'll present a fair number of cases today, and I think in the morning we'll probably do lecture in the morning. We'll do a few paper-based clinical exercises this afternoon. We'll probably do a cardiopulmonary screen this afternoon, and then we'll probably do a cranial nerve screen this afternoon as well. We'll come back tomorrow morning. We'll start with medical labs when you're fresh, so medical labs, complete blood cell counts, basic metabolic panels, those type of things. We'll start with that tomorrow morning. And then we'll probably do GI, UG tomorrow morning as well. Then the afternoon will entail an abdominal examination, hands-on abdominal examination. And then we'll probably end up with psych. But we'll talk about psych as we work our way through a little bit here, too, some yellow flags and screening and things like that, and we'll get through that. So that's kind of how things are going to roll out. But this morning we're going to present a fair number of cases to you, and the thought here is that, you know, cases I think are helpful because, they kind of, they're good and they're bad in some ways. People come to these courses and say, well, you're playing Monday morning quarterback, you have all the answers, but we're going to try and delve into these cases a bit to see what could have probably been done different, and we don't do that a lot as PTs, and I could ask you, the last 10 patients that had absolutely terrible outcomes with you, did you actually look at those patients and discuss them? And as PTs, we don't do that. Physicians do that a lot, and I applaud them for that. In fact, there's probably someplace on this campus where they do morbidity and mortality rounds. I'm sure there are. And so what I would tell you to do is sometimes sneak into one. Has anyone ever attended one of those by chance? Yeah, so what you have to do is you got to get a lab coat. You got to get a lab coat on. You got to get a stethoscope and wrap it around your neck. And you're going to pack a little sack lunch, so like maybe half a tuna fish sandwich and a little bag of chips and a juice box. And you just got to walk in. You just got to walk in. And what you'll appreciate there is how physicians critically analyze, especially negative outcomes, and how they try and learn from those. And as PTs, we don't do that, right? We want to present positive outcomes, kind of hang your hat on those. But sometimes negative outcomes we don't talk about. We're going to talk about those this morning a little bit, but I think that's what we want to try and do better. Okay. So this first patient here, 61-year-old male. He's referred to PT 3 weeks following an L3-4 discectomy. And if you look at the body diagram, there's some interesting findings. And so he definitely has low back pain, for sure. But then he also has pain along the lateral aspect of his right hip into the groin region. And he also has pain into his knee. And that pain into his knee is probably the worst area of his symptoms. One thing I will say, I don't know if you're doing body diagrams, but I think they are extremely helpful. Whether or not you do them, getting input from the patient, or have the patient complete them and then you clarify, but I think they're extremely helpful in trying to determine what's going on. Remember, we're trying to gather data. So they're referred to you 3 weeks following this discussion. Surgical indications were that he had severe low back pain and right lower extremity pain and weakness of the right quadriceps. So his quadriceps was weak and he had low back pain. MRI demonstrated an extruded disc at the L3-4 level. That extruded disc is probably an important term because we'll talk about diagnostic imaging. You probably know if we scan the next 100 asymptomatics coming out of Walmart, we're going to find probably 75% of those some type of disc pathology. However, maybe even more depending upon the age. But these extruded discs, we don't see these in asymptomatic folks. So if we do that those 100 scans, maybe one, maybe two might have these extruded discs. So these are large herniations, so we'll kind of show you a picture of this here. So on the left, there will be a sagittal view. MRI, so we're cutting the patient in half and looking at them from the side. And then anytime you look at these axial scans, the patient's head's out there and feet are out toward you, and we're looking up, right? So this would be posterior here, this would be anterior here. You can see the herniation is rather large. And, if you found out you had that in your pack, you probably wouldn't be happy, right? And this is not the type of finding that we say, that's the normal anatomic finding that's associated with aging. That's something probably a little bit different. So they went ahead and treated him right this guy. And so he's coming in, ambulating with a rolling walker at this point. 61, I'm getting close to that. Probably could use my rolling walker to get through here. It'll start to bother me a little bit. But the low back pain and that right hip pain, and he says he's no better. He thinks he's getting worse. I don't know how many people work with post-surgical patients here. People work with post-surgical patients. Yeah, so following a procedure like this discectomy, they follow up with the surgeon maybe 2 weeks later after the procedure. If the patient's doing fine, you never see him, right? The patients that you guys typically see are the ones that aren't better, right? So he went and had surgery, he's no better. And I would ask, what are you guys going to do? So just think for a moment. Just think for a moment. Just jot down a couple things as to what this visit would entail. with this particular patient. So what would you do with this patient? Post-surgical, which, you know, back in the day when I was seeing those patients, was supposed to be low threat, right? See patients following ACL reconstruction, Achilles tendon repair, you know, low back surgery, post-surgical patient. Should be easy. What would you do with this person? Remember, they're no better. We got a few things down. Chrissy's just thinking about it in his mind, just jotting it down. That way she doesn't have a pen or a pencil. You might think about what your physical exam might entail. You might think about what questions you want to ask this person. And of course, if you're like our game students, so I got to give the full slide deck too, by the way, right? Because you can't hold slides back, right? And then say I'm going to give them to you after the fact because I forgot to do it. So the game students would always scroll ahead a little bit. Wouldn't that be nice if you had a PowerPoint presentation on each patient? Scroll ahead, see the disposition, the outcome. How cool would that be? I always thought what I would like, if anything, I would like someone to come in and have their body shaded like a body diagram. All the symptoms are, symptom descriptors, etc. That's what I think. What do you guys think? What history questions would you have? What physical exam findings? What would you guys do? What would be the big thing you want to do with this person? No better. You throw something out. Amy's going to say something. You guys a little shy. Hip screen. Hip screen? You're going to go right to the hip? Incredible. I love it. Screen that hip. That'd be the first thing you do. Screen the hip. Anything else?
I would think a pretty thorough subjective, especially since it's your first time meeting this patient.
Sure.
They haven't seen PT yet.
Yeah. Well, they've seen PT a lot.
Oh, they have?
Yeah. So
But you haven't
better
already.
surgery. Yeah, and like I said, you know, not get better, get the MRI, see the big disc herniation. Anyone else right? The hip screen is important because at some level, when some of these cases start to go south a little bit, you look and there are some basic things that weren't done. So one good thing to do is always screen joints above and below, right? Above and below the area of symptoms, especially if you see concerns there. And this would certainly suggest that the right hip could potentially be involved. Potentially be involved. Anyone else, Mike?
Repeating the detailed neuro, just based on his weakness that he had previously.
Neurologic exam would be important. So I think, you know, you're going to take your historical questions. Your historical questions might lead you into examining some of those areas. But I think certainly screening the hip, looking at the lumbar spine again, and then looking at that neurologic examination, full thorough neurologic examination is all important. So thank you for that. And so when we look at, right, the hip, and the hip was important because when the therapist went out and got them, the guy couldn't sit in a low chair. You know, because I can't sit in a low chair. You know, disc herniation, you think, okay, can't sit in a low chair because, right, it's flexing his lumbar spine, it's causing symptoms into his lower extremity, but he couldn't sit in a low chair. So the first thing they did was, you know, start to look at the hip a little bit, and the hip was limited in terms of flexion, internal rotation, abduction. And if you can't recall, it's a capsular pattern, which suggests that there's something internal to the hip joint associated with that. Could get the hip beyond 70 degrees of flexion, internal rotation, abduction was essentially limited to zero. And they also noted crepitus, right? Crepitus as they're looking at the hip. And then the strength examination would be important too. So the strength of the hip flexors, extensors, abductors was all diminished, but it was related to pain. So again, these are basic concepts, but if you're evaluating strength and there's pain associated with it, you don't know if it's pain inhibited, right, or if it's true weakness. So you wouldn't know that. But right knee extensors were definitely weak, and there was no pain associated with it. So he had frank weakness of his knee extensors. And so that L3-4 disc, what nerve root would that compress? Go ahead and hold some fingers up. 3. Press 3. What is L3? do. Create interface quadriceps, along with a couple others, right? And we don't have data on patella tendon reflex either. So that disc herniation would add up, in fact, it's quadriceps. Right? So what would you do with this information in this particular point? I suppose you could treat the hip. This came from an orthopedic surgeon, call the surgeon, call the primary care physician, initiate a course of care. Those are kind of your options. How many people would initiate a course of conservative treatment for this job? 2, 3, 4, 5, 6. Numbers are creeping up a little bit. So we got 6. What would the rest of you folks do?
Your question about initiating conservative management, does that suggest that we are or are not communicating with the physician or some other team member?
You could. So what, if you did communicate with the physician, what would you say to them? Because the other thing that I hear, I hear this a lot, that it's sometimes challenging to communicate with physicians, especially the surgeon, right? Because now if you're going to call the surgeon and say what? What do you going to say to the surgeon? I think their hips involved, and I might recommend imaging of the hip. They may be open to that, they may not be open. And we've had these relationships with physicians, sometimes those can be challenging. So part of this is about communicating appropriate information to providers that have to do things that you can't do. If you could order diagnostic imaging of the hip, maybe you'd order it. Right? And so I would say, at this particular point, with this limitation right here, right, this limitation right here, and it produces all of his primary symptoms, as well as these findings here, that imaging would be the next best step. You'd have to contact the surgeon, most likely, and say, thank you for sending Mr. So-and-so over, but evaluating his hip, I am concerned that there's some impairments of the hip that could further be explored through imaging, right? And maybe they say, yeah, maybe they say no. But imaging would probably be the next best step. If you try to conservative course of care, you probably determine that he's not improving, and you probably pull the plug on that sooner rather than later. So here's his image here. So an AP view of the pelvis. So AP view of the pelvis is kind of nice because you can get an AP view of each hip, but an AP view of the pelvis gives you a bilateral comparison, right? If you lose a little bit of quality laterally, because the beam's going right through the middle, but you can still see what's going on here. So a nice healthy hip, right, on his left side, and what's going on the right side. Yeah, so they call it severe collapse, dissolution of the right femoral head, consistent with AVN, and severe advanced degenerative changes. And so this is probably the symptom generator, right? The fellow went on and had a total hip. And I'm going to put a plug in for these cases. Is anyone familiar with these JOSPT imaging cases? Show of hands if people are familiar. So they've been around for a while. So they started back in 2008. 2008, the feature started JOSPT. There were 50 cases published per month. There was one page with diagnostic images associated with it. The journal wasn't crazy about having these in there because they don't improve the impact factor. Impact factor relates to how often an article is cited, right? How often an article is cited. These articles don't get cited a lot, right? They don't get cited, certainly not like an RCT or systematic review or meta-analysis. So they kick them out and they actually form their own journal. So there's now JOSPT cases that just comes out, I think it's maybe once a quarter, and all they publish are these imaging cases like this, and then case reports. And so it's pretty good. And so I like it because it gives you that little 250 paragraph, 250 word paragraph, couple paragraphs down there, the images on top. And so he did great after he had his hip replaced, right? After his hip replaced, and 3 months later he was doing fine, working, no assistive device, got back to work and all that matters. The reason I know a little about these cases is because I was the editor of the section for the journal for 2008, 2016. So I learned a lot about these patients behind the scenes. cases that we wanted to publish were, you know, where someone had pretty decent clinical decision-making associated with the diagnosis versus I had no idea what to do, so we just got an image and something pops up. Well, we had no idea how we got there. Follow me? Those are a little bit challenging at that point. So what came out of this case was that. Well, let me ask you this. What would be some of the, why would this happen? Why would something like that happen? I mean, there's no femoral head. Are you guys impressed by this image? This guy's wandering around? Why would that happen? What are some risk factors for it?
History of alcohol abuse,
Alcohol abuse, he wasn't a drinker.
chronic tobacco use.
Corticosteroids would be another one, no history of that. We actually published a case about a young fellow, 20s, right, who had AVN in his hip, and it's one of the few that we could find that the only thing we related it back to was inhaled corticosteroid for controlled asthma for his adolescent years, and so not much about that. We certainly think about oral corticosteroids, injections, what else? Any other ones? Those are the two biggies. A history of Hertz disease would also be a concern, and that's what he had. So they went back and they looked at, and you know, they said this, you know, he had no corticosteroid alcohol use, right? But he did have Hertz disease as a child. And what's Hertz disease? It's AVN of the hip, right? But in an adolescent, right? It can be treated, but he had it. And so when the orthopedic surgeon found out about that, didn't know about it before the surgery, right? How do you think that went down? It's not good. It's not good. So a couple things come out of this. Number one, right? You have to do a good history. You have to look back at the medical record and try and figure out what some of these other things are. And at the end of the day, I think this is an extremely complicated case. That hip lumbar spine differential is very, very challenging. And so this is a patient who had a large disc herniation that you couldn't ignore. That's where they went, but no one screamed against them. No one screamed against them. Somebody has to make a decision at some point. It's the hip or the lumbar spine, and what am I going to do with it? And they went lumbar spine route, but that wasn't probably the best way to go. A couple things we can take out of that. Okay, so the other thing I want to mention about diagnostic imaging, we'll talk more about this. It's outstanding at showing the right? It really is. But at the end of the day, it's that clinical history, right? Clinical history and your clinical examiner is quite relevant to that. Any questions on that? Questions on that?
Was he treated in PT before he had his lumbar surgery?
He was.
So they never evaluated the hip or anything during their exam?
What I understand was I know more about these cases than I should because we did get into them a little bit. Saw a McKenzie trained therapist. What's a McKenzie trained therapist? If they were in the room, they would say they do other things. But what do they do 99% of the time? They do spine, but what are they going to get if they have a herniated disc? Extension exercises. Extension exercises. He didn't respond to them.
Was his body chart the same before surgery? Like the same
Was.
low back and hip pain and
Yep.
pain?
Yep.
And then the same after?
Yes. Same symptoms that they were dispersed. Good point.
Do we know how long his pain had been there?
The low back pain had been coming on, or what he thought, the symptoms were probably about 6 months. To the point where it was getting worse, really affecting his function. Trendelenburg gait, using assistive devices to offload the hip, etc.
So, and hip was not a intermittent factor for years?
Well, no one thought.
I mean, if you had asked him in retrospect, I've had a bum hip for a long time.
Yes.
He
would say that. But I think when you start doing imaging, like you said, you start to see that finding on that scan. You can't ignore that. That's not something you can say is normal age-related changes. We don't see that. So it's certain sees that that's the relevant. Yes, Chris?
When would you have asked like the special questions related to the hip? Would you ask that to yourself a little bit more information prior to requesting imaging?
so, but I think the fact that, he's not better after surgery, and the fact that his range of motion is that limited, that's probably enough for you to pull the string on evaluating. I would think.
Do you know if he had an impaired neuro before surgery?
He had weak quads. That
No.
was all that we know. He had weak quads.
I think that's also the significant part of the hip lumbar differential is because there is that huge extrusion. I know that extrusion is a bit better prognosis than a protrusion itself. And if his quad is progressing, it might have been needed to be surgerized anyways. I mean, maybe that's not the route that you first take.
Right.
But he goes and gets a hip replacement, he still has this huge extrusion, he can't move as well. Maybe his quad progresses even more and then his outcomes in that lower extremity are even worse.
That's true, we wouldn't know that for sure, but that's a good point. But again, could you be one of those 100 where that is a fact, and it's not playing out?
And maybe the quad weakness was there all along, or because of his Schindler gait, because of his hip, his quad was just weak.
That's right.
Because of atrophy.
Wasn't loaded. Very good discussion. Yes?
In your experience or understanding, how much or little of a risk factor would a history of hip dysplasia be in the risk for developing AVN?
For AVN, I'd have to probably look it up to see if you get a true dysplasia and what the relationship that would be with AVN. It's a good question. If there's a history of hip dysplasia, would that lead to AVN? I'd probably look at that. Because Pert's disease is a little bit different than hip dysplasia. That's a good question.
So Mike, reflecting on this case, I mean, he had a gigantic extrusion, which should make you have concern about cauda equina at some point.
Absolutely.
So Eddie was just saying, gosh, which surgery would be done first? And for me, if I'm the orthopedic surgeon looking at this guy, I would say, I don't want you to have cauda equina. That hip has been around for a while. We can do that when you,
That's right.
I mean, he needed both, right?
Well, you make a good point, and so, if you talk to surgeons who see that, they probably would treat that because of the concern. Right? Or you need to educate them to let them know that these things happen. You start to notice that you can't generate a urine stream. This is stuff that has to be evaluated fast. You probably got max probably 48 hours to turn that. You start to see it.
And with an extrusion, the only upside of that is your body eats it.
That's right.
Because it's nuclear material exposed to the cerebrospinal fluid, so, or to the fecal sac region, so.
I didn't put that in there. I didn't put this in. Someone mentioned the prognosis for this. So the natural history of these extrusions, about half of these resolve on their own. About 25% of them go away altogether. You regress. So if you can wait it out, and we'll talk more about that this morning. If you wait these out, sometimes even with large herniations, as long as there's not neural findings associated with it. So let's cover another one here. So this is a 53-year-old woman. She's 2 weeks following lumbar spinal fusion surgery. Now this is her 6th lumbar surgery in 2 years. So if you look at the body diagram, a little bit different here. This is a home health PT who lets the therapist, or lets the patient go ahead and complete the body diagram. So she talks about having some pain in her cervical thoracic region. She has what she calls pins and needles kind of in her left arm, moving down her left arm. She also has low back. And so when you have this type of picture, when you can clarify some of the symptoms the patient tells you about, another good question to ask is, do you have symptoms anywhere else? Is that fair to ask that? Depends how much time you got. Because you could have patients who got a 5 o'clock shadow everywhere, they're over that can of worms. But do you have pain anywhere else? And you said, yeah, I do, because the worst pain I have is my leg pain, and that's the reason all this started. That I have activity-related leg pain. What would be in the differential for that? Activity-related leg pain.
Neurogenic claudication?
Neurogenic would be one. What else? Vascular claudication. Sure, so those would be the 2, right? So to evaluate for neurogenic claudication, what would you do? Evaluate the spine with diagnostic imaging, so her MRI showed that she had a narrow spinal canal, right? Pain with walking, right? Thought this might have been spinal stenosis. So her surgeries really started with decompressing her lumbar spine and ultimately led to infection, a redo, and this is the image from her last surgery with this multi-level cage fusion. And so, again, you're seeing her after surgery, 2 weeks after this last surgery. This is in a rural setting, right? So she was in the hospital for a couple days after that, came home, and now you're seeing her. So her past medical history, CAD, coronary artery disease. She has depression, and she has suicidal ideation. She also has smoking history. So let's just talk about the depression and the suicidal ideations for a second. So how would you talk to the patient about that? Would you want to know anything about that at this particular visit? Would you tell you she has this? Depression and suicidal ideations. Yeah. You probably want to ask some questions about it, right? Because if this is true suicidal ideation, she's suicidal here today, and she has a plan. This is a 911 call. Let's just put that right in front. This is 911 call. Things stop, and she has to be evaluated for that. But what would you ask her about the depression and suicidal ideations? We'll talk about depression a fair amount as we work our way through this. We'll talk about it tomorrow a fair amount too. And, you know, depression is common amongst our patients. Depression is common for lots of different reasons. But if you ask her about her depression, right, one question to ask would be, is depression related to your condition? And how would you clean that up? If you didn't have this going on, would you be depressed? You follow me? And so if she said, yeah, if you got me 100% better, I would no longer be depressed. Does she need to be managed by somebody for that right now? Maybe, maybe not. But this is not an emergency call. Yeah, I've had suicidal ideations in the past, but I don't have them right now, but I have had them, right? My life is terrible. She was a third grade school teacher, hasn't taught for the last year and a half. And we'll talk about her function here in a second. It's not good, right? And she's not doing well with all these surgeries. And so again, with respect to depression, we'll talk about this. I mean, you know, if the patient says, yeah, if I was 100%, I'd still be depressed. Those are reasons that you want to get physicians involved. You can still do that here, and she's taking anti-anxiety medication. Someone's already identified this. But here are events here. So Neuron, which is actually an anti-epileptic drug that's sometimes taken for quote-unquote nerve-related pain. Percocet and opioids, some of the muscle relaxants, and Xanax can be used for sleep and anxiety. Okay, so she's taking those, and she has a smoking history. She's no longer smoking. And so, you know, I'd ask, you know, what would your examination entail for this particular patient? What would you expect the level of function to be? She's 53, right? 53. There's her image. And so the therapist starts by doing, you know, a basic cardiovascular screen, looks at her pulse and her blood pressure. Blood pressure's a little bit high, pulse is a little bit high, respiration's even a little bit high as well. And when you look at how she's transferring, you know, and this is always sketchy, what's a minimal assist, moderate assist, max assist, moderate assist. Moderate assist in this particular case was the therapist needed to give her help transferring from supine to sit, and then from sit to stand, right? He had to physically help her do that. Okay, so that's what they classify as being moderate assist. And she needed moderate assistance to ambulate 9 meters, close to Canada, so sometimes we talk metric system. 9 meters is about 30 feet. So it's probably from about here to there, right, here to there. And she almost passed out. So she was SOV, shortness of breath, lightheadedness, and extreme fatigue, and she had to sit down after walking for 30 feet. So is that a normal physiologic response for a 53-year-old woman status quo to 6 lumbar surgery? Because that's what you're asking yourself. And if you ask, well, how many providers have you seen up to this time? We count them up. 54 different providers that she's seen over the course of this 6 years. That's including PT, inpatient stage, nurses, physicians, surgeons, anesthesiologists. So they let her go home, and the thought was that this is a normal physiologic response. So how many of you would think that this is a patient who's deconditioned, and I'm going to initiate a plan of care to improve her condition? This is just good old deconditioning at this point. By the way, her leg pain's not better, right? After you do 6 surgeries, decompress an area, and the leg pain doesn't get better, at some point, you gotta start asking yourself some questions. Leg pain's still not better. Right, but the reason she can't walk past there is because of extreme fatigue, lightheadedness, and short spurt. So how many of you would initiate a course of care for her? Would anybody do that? Well, if you're not gonna do that, what would you do? Anyone want to? Any second, okay.
Maybe some diagnostic ultrasound, vascular ultrasound.
If you had it, what would you, I don't know what you call it.
Yeah,
Case like this, I just think always, it's really easy to assume that the worst has happened, and so what am I looking for? Treat what you got. She's depressed, it's been a rough go, she's anxious, so treat it out, because 54 people have seen her already. So you have a tendency to stop thinking, not stop digging.
And it probably wouldn't be a wrong answer, because that's what's been happening all along. Would anyone do anything different? And again, this course is about building relationships with people that you can talk to that can answer hard questions like this. And so my charge to all of you is, at some point within probably the next month or so, develop a relationship with a physician. You can actually text somebody and ask them a question. I don't know if any of you do that, but that's a good thing to be able to do. You can't get a physician, get a PA or a nurse practitioner, somebody you can talk to, right, that you can bounce some of these clinical cases off. Because if you call the surgeon, what's the surgeon going to say? Nothing new to me. I know she's deconditioned.
So the other thing, Mike, is she's on narcotics and she's on Neurontin. Both of them actually lower blood pressure.
Right.
So I would wonder what she'd be like. I mean, I don't know how long she's been on Percocet, probably a long time.
Yeah.
But that drops your BP, and so I wonder what it would be if she wasn't on those.
And her
medications.
respiration rate too.
Yes.
That's a really good point that no one's ever brought up. Blood pressure's high. So bottom line is blood pressure's high, if nothing else. 160 is not something which we want to be going. And she had activity-related shortness of breath. I would say that's probably not normal requirement, even if she's deconditioned. She should be able to walk from here to there without fixing the next up. The therapist in this case called the surgeon. The surgeon said, I called the primary, which is very interesting, because surgeons oftentimes will say, but you want anything to do with this concern over a cardiovascular concern. Called the primary said, I'm not sure what I can do, but the therapist had a relationship with the cardiologist who we contacted, who wound up seeing the patient. The next day. So they had the brain transfusion for his death, see the cardiologist worked her up, and the workup was a lot more complicated than I'm putting right here, but cardiac catheterization was also happening. She had severe stenosis of at least 3 major vessels in her heart. And so the big one here would be this left anterior descending, and then this right coronary artery. This left anterior descending provides blood flow to the majority of the heart. So that's a 75% decrease there, and then these other 2 were concerning as well. So she underwent a coronary artery bypass graft, and then 10 days after that, she's back home. The therapist is evaluating her. Same therapist, 10 days after that surgery. She's back home. And she's in the hospital for like 4 or 5 days. The therapist is seeing her 10 days after that. And so what would you expect from her now? Would you expect her to be better?
I would hope the left arm pain would be better. If
Yeah, I
that
mean,
was a
you
cardiac
look at this
issue.
body diagram, can't you? I mean, look at the left body, look at the body diagram. She's telling you she has pain down her left arm into the back, region. You would hope something would be better. And so when he sees her, right, she still has some post-surgical chest pain. Her low back is still sore, but she's still about, I think I looked back at the time, she's still about 6 weeks out from that last surgery. But her low back was just sore, but it was better. And around the house, and this was in a rural setting, and the lady actually said, can we just go outside and walk? And can I do that? So, because I've been walking around the house, no problem. So 300 meters, which would be a football field 3 times, right? And if you've ever done home health, you gotta have the patience to see, you can't be here all day. So he just cut the cord at that point and said, you know, doing really, really well. SBC single point came, and she didn't have any lower extremity pain. So lower extremity pain was not normal. And then she had no shortness of breath, no lightheadedness. All of her medications kind of dissipated as well, so no more Percocet, no more Soma, no more Xanax. She stayed on a Neurontin. There was some thought that she might have had maybe some restless leg syndrome. You guys heard of that? Neurontin probably helped with that. Started on Lipitor, which is a statin. Like I said, she continued with Neurontin. So she continued to be treated by the therapist in the home for a conditioning program until she was 30 drive. Then she was able to go to a cardiac rehab program at the community hospital. And so, again, this is one of these cases that you have to ask, how did it get to this point? You know, how did it get to this point? And when you talk about that differential diagnosis, right? Activity-related leg pain, neurogenic versus vascular claudication, right? Where are you going to go with that? Well, she's 53. The likelihood of vascular claudication in that age, right? Especially in the legs or related to the heart, right? Probably low. And again, she's had these multiple lumbar surgeries and she's not any better. Not any better. Right? And she has a history of coronary artery disease. We're not sure exactly when it was diagnosed, but the findings of elevated blood pressure, shortness of breath, fatigue, lightheadedness, all relate to the cardiovascular system. And that pain presentation, right? Symptoms in the left arm and the back, and she called it pins and needles kind of in her left arm. It wasn't necessarily pain, it was kind of pins and needles. And you could have said good for them. Right? That's really what this comes down to. But hopefully getting to the bottom line answer sooner rather than later. So people don't have to go through all of this, right, and get involved in it. So we thought this was an interesting case. We sent it to PT Journal. What do you think PT Journal thought about this case?
That it wasn't interesting?
We sent it to JOSPT though. What do you think they thought about it? Their responses were this is just doing nothing more but airing. Now I think there's some learning points out of this. What do you guys think?
Yes.
We eventually found a journal. You know, we took Dr. Tall as a radiologist on the paper. Dr. Senko is a cardiac certified PT who looked at the case and said, you know, this is just craziness. You know, but no one wants to publish this kind of stuff. Right? And we'll publish positive outcomes. Have little kids with CP in the covers of our PT stuff. You know, working with therapists, maybe somebody with, you know, Parkinson's, you know, punching a ball or something. But we don't want to talk about that. But I think there's some learning points out of this. And so a couple things came out of this. So this whole business of, you know, women and cardiovascular presentation is very interesting. And this course used to be, when I first taught this, I think back in like 2003, this course was about screening for real red flags. So we talked a lot about cancer, we talked a lot about fractures, we talked a lot about clot equina, seronegative small orthopathies, things like rheumatoid, how these things present. But then as we started to teach this, you know, we started to say that those things are pretty rare. If you find those things, you know, you probably are finding kind of a zebra. But what about things like cardiovascular disease? What about things like depression? What about things like diabetes? You know, these things are right in front of us, they're not being managed properly. The course has shifted in that regard. So one area that we are interested in is MI presentation in populations that don't have this atypical substernal crushing chest pain. And I'll be standing on my chest, you know, and I'm getting this pain shooting down my left arm. So what are the ramifications of that? And so, you know, when we look at that, about a third of patients with an MI don't have that symptom presentation, right? So kind of like the patient we just talked about, right? They don't have that substernal crushing chest pain. Does anyone know where that substernal crushing chest pain shooting down the left arm, radiating from the jaw? Does anyone know where that came from? Like what population did that come from?
Males.
you know, this has not been going on that long. I mean, if you think about this cardiovascular stuff didn't really kick in until like the 70s and 80s, right? So this was pain patterns with typically middle-aged Caucasian males, right? That's how they typically presented, probably from the 50s and 60s, data from that. And so who doesn't have that? So women don't present that way. Folks who are diabetic and the elderly don't present that way. But what are the implications of that if you don't have that, right? There's a longer delay before hospital presentation. Why? Because they say there's something else probably going on, right? I have other symptoms that don't seem to be related to the cardiovascular system. They're less likely to have an MI diagnosis and seek primary treatment, but the big kicker here is the mortality rate. So if you don't come in with that, the likelihood of you dying is like 1 in 4 versus 1 in 10, right? So there are huge implications for that. A couple other interesting studies that have looked at this is during a heart attack. So this looks at symptoms that women have 1 month before and then during a heart attack. If you look at those symptoms on the right, you don't see pain up there, right? You don't see that. You may see shortness of breath, weakness, fatigue, dizziness, all these other symptoms that can be explained by probably something else. But if you go over to the left, right, we call them prodromal symptoms 1 month before. So the two big ones are fatigue and difficulty sleeping. Those are the two big symptoms that occur 1 month before these folks have this massive MI. Does anybody ask their patients about a general health screen? Does anybody ask patients if they have fatigue? How often do you get you're shaking your head, I don't know your name.
Rachel.
Rachel, how often do you get a clock? You ask your patients about fatigue?
I do sometimes because I see a lot of vestibular patients.
Yeah. You want to do a lot of patients have fatigue?
Oh yeah, I'm tired all the time.
Yeah, so I'll share my intake with you guys, the one that we use. I don't know if you guys use intake, but fatigue is probably the one that's probably checked the most. It's one of the most common reasons that folks come to the primary care physician. So if you ask questions like Rachel about fatigue, and you get a positive response, you have to know how to figure out if that's a concern or not, right? And so, but I would tell you that it's a common complaint. If you start asking about it, you're going to get positive responses. Do you ask your patients about their sleep? You should be. Yeah. You should be. And how many of your patients have difficulty sleeping related to their symptoms? A lot do. Right? So if you look at fatigue, very, very common. Very, very common. We'll talk about this probably after lunch. We'll talk about what I would recommend that you do for all your patients. And it's not just me. I'm coming up here to spout stuff off. So these are kind of consensus-based guidelines that you should be doing, just good quality of care. Right? So we'll talk about a general health screen that you should probably do on every patient. And one of those questions is fatigue. Right? It is common. Right? It is common, and it's a normal response for several different reasons, right? But if there's longevity to it, and it's unexplained, right? If there's longevity and it's unexplained, that's when you have to intervene. This happens a lot, right? I see patients and, you know, I'm seeing them for whatever reason, let's say it's low back, and they check fatigue, right? They check fatigue, they've just been seen by the physician, referred over. And so, if the fatigue has longevity, it's interfering with their function, we'll talk a little bit more about that, and it's not explained, what should you do with that? Let's say they're telling you, yes, I had fatigue interfering with my function for the last 4 weeks, and I don't know why, right? Same job schedule, right? Nothing new going on in my life. I talk to the students, right, when they come back from break on January 22nd, if I ask them, are you guys fatigued at 8 o'clock in the morning, how many would say, yeah, I am fatigued. And the fatigue will probably last for a few days until they get used to their schedule again, because they're not getting up at 7 o'clock, rolling out of bed, and they're sweating and coming to class, right? So they would have fatigue. That's a good reason for it. I've just changed my job schedule, right? I just saw one of our maintenance guys on campus. He worked first shift, 8 to 4. He switched off to third shift. Now, would he have, if I saw him, would he have reason to be fatigued? Yes. How long would that take to resolve that fatigue? You switch from working 8 to 4 to 12 midnight to 8 a.m. How long would it take for that to resolve?
I don't think it would ever resolve.
Well, I got done last night, 1 a.m., your guys' night, which was 4 a.m. And the craziest thing was I should have been sleeping or doing other things, but they had a TV on the thing. and they had the Pete Rose documentary for 4 straight hours, so I got into that. I like to fly first class, so flight attendant was helping me out with talking to my friend Jack Daniels on the way, so I was really good, I wasn't driving, so I didn't care. So should I be fatigued? Yeah, I probably should. I feel good though, my energy level I think is pretty high. Got a good workout in this morning, so I feel good. So we'll talk more about that, but back to my point, is I could send a patient back to their physician for this complaint of unexplained fatigue that's been going on for the last 4 weeks. Because when they make the call back to the clinic, right, you're still gonna see them for low back, and it's unrelated to why you're seeing them. But they tell you they have this complaint. And there's lots of different reasons patients can have it, right? Some of these are pretty serious. Now, how many of you can work your patients up for any of these? Maybe musculoskeletal disorder. You can't. And so you're gonna send the patient back to the physician who they just saw, so you have to kind of coach them a little bit. This isn't something that you need to intervene on their behalf. I give them my business card and I say, call your physician's office back, right? And I put the information in the back of the card. You're calling for a complaint of unexplained fatigue for the last 4 weeks that's interfering with your function. Okay? It's not related to why you just saw the doctor, okay? And then I write a little letter, it's a form letter that I just say, thank you for sending Mrs. So-and-so over for evaluating and treating for a low back. I'm sending her back to you because she's told me about this complaint again of unexplained fatigue for the last 4 weeks that's interfering with her function. And I've been doing that now for a long time. And I've never been called out by her. I'm just gonna tell you that. And maybe I'm intimidating and they're not gonna wanna fight me. I do have a wrestling and MMA background, so. But they don't. But my point is, it's communication. And they don't want to talk about low back pain, but can they work up fatigue? Do they know about working up fatigue? Yeah, we have a PA school. How much do they know about the low back? They get like a day of musculoskeletal. A day. But how much do they know about this? Yeah. Let's talk about sleep. So bottom line is fatigue.
Like when we're talking about differential diagnosis of this broad, especially in middle-aged women, we're seeing a decent chunk of our primary care docs chunk this up to perimenopause.
Sure.
Right? I mean, is there anything in the literature that you've seen that is, like in this differential, that differential slide, like you look at menopause or perimenopausal symptoms, a lot of those show up. And so I just have seen that be kind of a new soup du jour of,
Sure.
You're going through a lot of hormonal changes. So hang in there, Tiger.
Absolutely. And I think, let me say it this way. Well, I'll go back to it, but let me just clean up sleeping for a second. Let me clean up sleeping. If you don't ask about sleeping, you should. Some of the best handouts ever that I got from Mike dealt with those alterations in sleeping posture to help patients sleep. Because if patients can't sleep, they're going to be miserable. So I would tell you, if you're not investigating sleep, go ahead and do that, because I think the buzzword at CSM probably 4 years ago was everybody was in the sleep hygiene, right? Talks on barefoot running were like 20 years ago. Hygiene was like 5, and then they just disappeared, right? No one talks about sleep anymore, right? But it's pretty important. Ask your patients about it. If patients tell me they can't sleep, I may spend a fair amount of time right there at that visit, helping them find a physician they can come to, right? But this study is very interesting because these are patients, 99 of them I believe here, 99 who had mechanical low back pain that was evaluated either through CT or MRI. So there was no pathologic findings, right? There's no sinister, nothing cancer, no fractures, cauda equina, anything like that. What they found was that about 60% said that they had difficulty sleeping. So that's 6 in 10 patients with low back pain say they have trouble sleeping. But only 1 said their symptoms were worse at night. Okay? So for the fellows in the room, I'm not exactly sure how this is going to roll out. I think there's going to be an examination. If I didn't tell you guys this already, there's going to be an examination at the end of this that you guys are going to have to take. One of the questions on there is going to be, when is night pain a red flag? So night pain's a red flag, because if you heard that, night pain's a red flag. Patient may tell you difficulty sleeping. Is that the red flag? Not necessarily. I just told you 60% had it. But when they tell you it's the worst symptoms that they have over a 24-hour period when they're trying to sleep, that's when it's a red flag, okay? Because we had one who said, they don't tell you. That's not when their symptoms are worse. It's not. So if you get that, but this is different. These are women who are telling you, I'm having trouble sleeping and I'm having issues with fatigue. My point is if you start to ask these questions, you're going to get positive responses. Slide. I'm going to go back to Ryan's statement for a second here. And so if, and I'll show you some patient profiles. If you had a patient that was being, and I'm going to talk about a cardiovascular screen that we've been doing for probably about the last, since probably 2010. It's a screen through the American College of Sports Medicine looking at cardiovascular risk factors. And we'll talk about that. And we'll talk about how to stratify patients into mild, moderate, or high risk, low, moderate, or high risk. And then based upon the activity that they would like to do with their risk stratification, that might potentially drive referral. And when we present this to therapists, they don't want to take it on because now you're gathering risk factors, now I have to do something with it. And they think that, okay, I'm going to gather all these risk factors aren't going to be appropriately managed, I'm going to get these folks back to the physician. You know, we deal with lots of older populations, things like that. Only about 10% of these patients actually need to see a physician. My point is this. If you had, let's say, a middle-aged woman who's complaining about these symptoms, but all of her cardiovascular risk factors have been evaluated and managed, that would be a reasonable thought that they could be perimenopausal symptoms. But if they're not being managed, and they've got things like blood pressure, they're overweight, they're smokers, they're sedentary, and they haven't seen a physician for a while, this kind of has to jump up to the top of the list. You guys haven't heard about this cardiovascular thing, it's kind of a big deal. Like leading cause of death in this country. I just told you about how it's misdiagnosed all the time. Because how do you work this up? We'll talk about it tomorrow. How do you work this up? How do you work up an MI? Patient comes in, they have these weird symptoms. What do you have to do? You have to take lab tests. And sometimes those lab tests don't show up positive for how long after? So if you took a troponin level on someone who's having a heart attack, and it's acute MI, it may take up to 24 to 48 hours for it to be elevated. So somebody has to make a decision to admit this patient. The conversation I had with Michael, do you think physicians are willing to admit patients with a low enough suspicion for something like this? They're not going to do it. You're going to get called out. Especially if those labs come back as normal. So you have to admit the person and then wait for these things to happen before sending them home.
Mike, before you leave that slide, I wanted to just highlight what you said when we started that case, is we should ask patients if they have any other symptoms. And I think, you kind of glossed over that a little bit earlier. That's really a big hope, like a take-home point.
Yes.
In this case in particular, we are fearful of saying any other symptoms, and then it's like, oh my goodness, like you called it, what'd you call it, the 5 o'clock shadow? People have pain everywhere, but it's important to know those things, and then you combine that with somebody who's had 6 surgical procedures, and it's incumbent upon us to dig a little bit, even if we don't want to and don't have the time to.
And determine if that leg pain, when she gets it, do you also get your cervical thoracic pain and pain in your left shoulder and your left arm? And she would tell you, yeah. And you'd ask, well, what activities bring that on? Right? Because left shoulder pain, what would you ask her? Well, when you reach to try and grab your oatmeal out of the top shelf, does that hurt your shoulder? No. Does it hurt when you turn your neck? No. What causes my cervical thoracic and my shoulder pain? That's when I'm walking. Especially if I'm going up and downstairs. My shoulder's killing me. I was having left arm pain yesterday. Thought I was going to make it out. See myself dropping dead at Dallas Airport. I'm saying to myself, I'd exercise hard right before I went to the airport. So if I was going to drop dead, they said I was talking to Christy all the time when I was working on 7. So bad lunches. I don't know if I was running downstairs a couple times between patients, I'm gonna drop dead, this is a good place to do it. I didn't know if I was having. So anyways, any questions on that?
Thanks for covering that again.
Yeah, and, and I didn't mean to gloss over that, but that body diagram, I think, is extremely important. Not everybody does. That question about, do you have symptoms anyplace else? We have the case in here, we saw one at Travis, very interesting, because, they make people in the military run, right? So this is a young woman, early 20s, who had primary knee. That's why she was coming, because she couldn't run, so they have to come to PT, get put on a profile, because you get a lot of trouble, you can't run when you're in the military. And the therapist, I give her credit, because she was coming for her knee, do you have symptoms anyplace else? Because all she said was about her knee. She pointed to her neck, I have pain in my neck, right? What's that about? Well, I jumped into a pool 2 weeks ago. I thought it was a lot deeper than it was. I went head first and hit my head at the bottom of the pool. And I always tell therapists, because they might say, you have multiple areas of symptoms, what would you like me to evaluate today? Because I can only do one. Who should make the call on what they evaluate in that patient, her neck pain or her knee pain? You should make the call. And what would be more important to evaluate? I get her telephone syndrome, she can't run. But what should she have, if you only have 20 minutes, what should, that's what this point was, what should she have evaluated that day? The neck. And she had multiple fractures in her cervical spine. So there's some really good points that come out of that, as to what you should be evaluating are the symptoms related to the second. I like to take breaks. We usually would say, at least I would, every 50 minutes, right? We have some faculty who just grind for hours, but I know you guys like to. Let's take a little break. We'll come back when the big hands on